here, if you will. Can everybody hear me all right?
Yep.
Okay, well, welcome everyone. Thank you all for being here and thank you for having me. My name is Pavitra Krishnamani. I am a graduating medical student with fellowship training in healthcare innovation at Thomas Jefferson University. During my fellowship, I worked with Jefferson's Digital Innovation and Consumer Experience Group. And I realized that virtual health solutions can oftentimes be broken down into unique components, tools in our toolbox, if you will, that can be used to build or facilitate the building of all sorts of innovations. I think of them a little bit like Legos. All sorts of different colors, different shapes, you know, just waiting to be turned into the next guy with his Lego gut spilling out. Or man with a puzzling MRI because someone finally figured out the key really goes in his ear. And in our conversation today, we're going to discuss the building blocks of virtual health and how we take that stuff and make it into something meaningful. Because understanding the anatomy of our virtual health solutions today can help us imagine and create the inventions in the space of tomorrow. So we'll start off talking about some of the building blocks of virtual health and then use a case study to take a closer look at an example of how they've been synthesized. Sound good? Okay. This is going to be a little interactive, so you'll see kind of points in the middle where I ask for your participation, and I would appreciate it if I didn't have to stare for like 5 minutes for them to happen. Yeah? Okay. So many of these blocks, these tools, can be split into 3 major categories. The technologies that fall into the category of digital infrastructure, they can be thought of as the platforms or the engines that underlie and really power virtual health solutions. Health technology, that encompasses more complex hardware and software, things that we see used almost exclusively in clinical environments and things that we're very familiar with. You know, these also include innovations that were the virtual health solutions of yesterday, but they've just become so integral in our practice every day that now they're kind of distinct components of even larger virtual health solutions. Lastly, we have mobile devices. These are the consumer devices that are available and can be made available to the general public. We'll review each of these categories individually and consider how the tools within each can be used in virtual health innovation. So our first tool comes in the form of voice assistants. These are the Alexas, the Siris, and Google Assistants of the world. And as Silicon Valley keeps showing us through demonstrations, they can get pretty realistic until they ask for a woman's haircut. Not sure if anybody heard of that. Okay, so Google demonstrated its assistant and had it schedule an appointment for a haircut. The problem is the assistant was speaking in a female voice, and instead of asking for a haircut, asked for a woman's haircut, which is something that you're hard-pressed to really find any woman say when they're asking for a haircut. But otherwise, fairly realistic. They have the potential to help our patients schedule appointments and reach out to emergency medical services when they need health assistance. And for the elderly, the disabled, the visually impaired, this can really help qualifying patients live more independently, which we've seen empowers patients in a way that can greatly improve quality of life. In the hospital, we can connect these technologies with smart devices and healthcare technologies, using them to answer some of our patients' queries and give them more control over their clinical environment. So we can use things like the Internet of Things that can really connect things like an Alexa or a speaker, some sort of voice assistant platform, if you will, with the thermostat. The stuff we see in our hotel rooms today, if you will, where we say, Alexa, turn the lights out, and it turns all the lights out, which just gives me a kick. But it also gives patients a kick when they're in the hospital with that sort of technology. And it helps them feel like that hospital experience is more their own. From a provider standpoint, we can use this technology to enhance things like the call bell system, to streamline nurses' workflows, giving nurses more insights into what a patient's requests might be before they even set foot in a patient's room. And I've heard from nursing staff that this is particularly helpful when you have a patient who has precautions, and now you're walking into the room trying to figure out what they need. You leave, they say, hey, come back, you've go back in and you're asking again. It just takes a lot more time for nursing staff to get that one task done and to prioritize that task. Using video call platforms, we as healthcare providers also have the opportunity to reach our patients when they aren't in the hospital. And we've talked a lot about this today, so I'm not going to dwell too much on it. But these form the basis of telehealth and telemedicine solutions that have helped address geographic and temporal barriers to care. They've gained particular traction as pre-hospitalization or pre-hospital triage tools. And they have the potential to decrease overutilization issues that many emergency departments face. Knowledge platforms such as WebMD and Medscape also play a role in how patients seek care. They empower patients to process complex information and ask kind of insightful and important questions to them during office visits. And they've been incredible tools to combat the barriers to healthcare that arise with poor health literacy, which is unfortunately what we see not just around the world, but here at home in the US. Provider-oriented clinical knowledge repositories based on research and study databases, those things have played an important role in medical education and the development of point-of-care decision support tools. They also power artificial intelligence algorithms that generate critical insights for providers to use in their practice. Health technologies, as I mentioned, are the things that we're quite familiar with already. Of course, this includes the clinical and patient care devices we see in the hospital. Clinical devices such as imaging tools can be augmented with artificial intelligence to influence post-processing of an image and assist with image interpretation, to a certain extent, of course. Patient care devices such as hospital beds can be outfitted with sensors that detect pressure or acceleration to provide better insights into when to turn a patient to avoid complications that occur with a hospital stay like pressure ulcers. EHRs, or electronic health records, like Epic and Cerner, despite mixed reviews, serve as a repository for individual patient records, fundamental to sharing information about a patient and painting a more complete picture than what we may see during a specific visit. They can be integrated with decision support tools to provide patient-specific insights, and on a larger scale, they can provide population health recommendations, both at a local and a larger scale. Lastly, our decision support tools can help guide us in everyday clinical practice. And they allow for a data-driven approach in doing so. They're excellent tools for provider learning and ensure newer providers don't miss critical steps in patient care. And that's important for somebody like me who's going into residency and is just learning this trade. M-Health devices, they're really your commercial health monitoring tools like Apple's smartwatch, the Fitbit, or Bluetooth blood pressure cuffs. One of the devices a patient of mine used was called the Cardiaband. He used it to measure kind of episodes of atrial fibrillation and A-flutter to try to make a more informed decision on whether he wanted to pursue an ablation. This kind of thing, these sorts of devices, they're there to provide real-time monitoring for both patients, but providers, because providers can take advantage of that information and get a better idea of what's happening with their patients outside the hospital. These devices can link up with phones and tablets that have kind of become mainstays of communication in our lives, and they allow for analyzed information to be transmitted in a palatable way for both providers and patients. They play a significant role in improving patient-provider communication, although improving patient-provider communication, if used right, I feel like is a caveat that needs to be put in there. From a clinical standpoint, they make health technologies like EMRs and decision support tools more accessible to providers. Lastly, we have hardware that originated in the entertainment industry, like augmented reality and virtual reality headsets that are now available to a much larger population. And appropriating them in healthcare has proven fruitful in developing psychiatric therapies, developing methods of pain management, stress management, they really have the ability to help with increased patient motivation, patient education as well. And that's integral to kind of the overall holistic continuum of healthcare. They're fantastic simulation tools when it comes to education for providers, and in the not so far future, they could also hold a place in assisting providers in more remote locations with procedures. And this is kind of my area of expertise. I'm a bit of a VR nerd. I worked a lot with virtual reality while I was in fellowship and worked on creating an ACLS or code blue simulator using the technology so that providers or trainees would be in a more kind of realistic environment. They couldn't escape the situation, and we gamified the entire thing, so people had to go through and kind of voice out commands and figure out what to do next in the moment, on the spot, in a timed sort of situation, or they got kicked out of the game and had to start all over again. Which was fun. We were voice training this thing because every so often we had to put in different things that the program would understand and say, no, that's okay, that's what this person is trying to say, and we had to try to make it palatable for different accents as well. Now, those were a lot of tools we just discussed, but the art of virtual health lies in incorporating those building blocks into solutions that transform healthcare by enhancing connectivity between and within healthcare systems, empowering patients to kind of take charge of their own healthcare and communicate information with their providers, and elevate medical training in a way that's, enhances both standardized and asynchronous training. And in the process, if we consider the stakeholders we impact, the patients, their families, providers and clinicians, and of course, system administrators and leadership, we can really use emerging technologies to improve healthcare quality and access. We can change the kind of care we provide, harnessing data-driven clinical insights in our practice and delivering care through more, continuous and meaningful interactions with our patients and with their information. So before we keep going, I want everyone to humor me a bit and grab a piece of paper and a pen from those flat boxes that are right in front of you. And I want you all to think about a virtual health solution you've seen in your own clinical environment or clinical practice and work backwards to try to identify which of these building blocks are present in it. And we'll just take a couple of minutes to do that. Think about that, write it down, and I'd like a few of us to share those examples with the group. Does that sound okay to everyone? This is by no means a comprehensive list. This is just kind of the major ones that I've seen in some of our virtual health solutions today. Okay, so does anybody want to share with the group? Yeah. Share kind of what the solution that you've noticed is and some of the components that have been used in it that you've identified.
We've built a chat bot on our sort of website, and we're actually integrated into a voice assistant, so it's going to have its own cute little name. And it's fun. It's interesting. It's interesting because how do you authenticate a user, and what does that mean when you're actually logged in, and what you can do. And again, to make an appointment, right, it has to know it's you. Yeah, voice assistant.
Very cool. Anyone else?
We're doing a statewide high-risk OB management program, and we use video conferencing, but we're also trying to do machine learning for prediction of high-risk patients that would be costing a lot of money and having bad outcomes. And then planning health monitoring to monitor blood pressures and other devices in the home to be able to monitor those patients outside of the hospital environment to drive down costs.
Very cool. And I think I missed you, right? Kind of thought to share.
Sure. We have a health technology, a couple of applications that help our members manage mental health, cognitive behavior. So we have several in our suite.
I'm thinking about our telegenetics program uses some of these things. So decision support tools, and then our knowledge databases to push when a patient is, may be genetically inclined to have certain cancer. We've got an app that allows them to
on each of these, so at least the ones I'm more familiar with. You've got the mHealth devices, the digital otoscope, stethoscope, et cetera, and most of those platforms now have a tablet to support the video interaction. For sure, they have decision support tools, and then on the infrastructure side, the video call platforms, typically knowledge bases, sometimes unified communications are behind the scenes as well.
Awesome. Well, thank you everyone for participating. It's fantastic. Let's jump straight into our case study. This is a case study looking at virtual health in the diagnosis and care of tuberculosis. So our case, a 53-year-old woman located in rural Nepal presents to a small local hospital after a 2-month history of cough with blood-tinged sputum. Now with 1-week history of sleep-disrupting night sweats. She was never a smoker. Her LMP was 2 years ago, and she doesn't really know her past medical history. She can't really remember the last time she saw a physician. Now obviously we know this is a case about tuberculosis. So instead of a differential, I'm going to ask you to put yourself in her shoes for a moment and think about the challenges she may have faced seeking care, so far in the process, and the things she may face in the hospital right now and moving forward. So let's start with what happened before the hospital. What are some of the challenges she may have faced getting to the point she's at right now?
Just seeing the healthcare provider model,
Mm-hmm.
access to healthcare.
As in not enough qualified providers around, or?
Yeah, and maybe not access to a provider or someone that can see your provider, traveling long distance.
Right, travel.
Access to a provider.
Mm-hmm. Okay, what else? What else could be contributing?
Her responsibilities outside of taking care of herself, so
Mhm.
family, extended family.
Absolutely.
She may not know how serious, potentially serious the issue is. She just maybe
Health
not
literacy.
educated about that.
Mm-hmm. Definitely.
Does anyone say compliance with medicine? That's a big problem with TB.
Yep, compliance with medication. That's something she might face in the present or the future too, because as of this moment, I don't think she knows she has TB quite yet.
Afraid of
Sheer
potential
for
costs.
receiving cost, it may seem nominal for us.
Cost of care.
Cost of care.
Yeah, so you guys touched upon some really great points. Sparse transportation infrastructure to travel to the hospital, geographic barriers in distance and terrain to healthcare providers, limited patient education, literacy, time constraints because of other responsibilities, certainly socio-cultural expectations and possibly the conditioning of women to prioritize family responsibilities over themselves or other things, based on cultural background. And in some places, the fatalistic belief about disease informed by a cultural lens. How about in the present, in her hospital situation right now, and in the future, kind of for her? What are some of the challenges she may face?
Stigma,
Mm-hmm. Stigma.
cost,
Cost.
yeah,
Yep.
availability, follow-up.
Mm-hmm. Following up.
Resistance?
TB resistance, right? In a lot of Southeast Asian countries and South Asian countries, we have multi-drug resistant TB being the prevalent version of tuberculosis, and sometimes XDR TB, which is a whole other thing. Other things? Yeah, so you all touched upon most of those points. Certainly, poor follow-up after leaving the hospital because of the challenges that she faced even getting to the hospital in the first place, the cost burden of care, geographic barriers, time constraints, transportation challenges, and then in the hospital at that moment, limited infrastructure, diagnostic and therapeutic, limited training and skill of providers in a local hospital, and maybe difficulty getting to a hospital that is more mainstream, that has more infrastructure available, because of things like travel and geographic barriers, and time, of course, cost as well. And so, all of these challenges are ultimately what lead to the problem in this space, recognized by the World Health Organization as the 3.6 million people with tuberculosis who are missed by health systems every year. To start to tackle this problem, a company called Semantic MD created a platform for artificial intelligence to address the human and physical infrastructure barriers to early diagnosis of tuberculosis that are present in the majority of developing countries, where tuberculosis is most prevalent. This includes limited access to radiologists and kind of subsequent and sometimes consequent provider proficiency in study interpretation. And of course the fact that chest x-ray is the most accessible imaging modality in a lot of these places. CT scanners are harder to come by, and non-imaging or molecular testing is just far too expensive. And so what they created was called CXR-AI. It's an artificial intelligence program trained to detect lung changes and read patterns commonly found in all sorts of pathologies, including tuberculosis. And it's trained to find patterns that are found in early tuberculosis. And this is important because there's not really one pathognomic sign on chest x-ray for TB, but there are a lot of different little signs that can be picked up and give somebody the suspicion of tuberculosis in its earlier stages. The algorithm and its records can be run from these tiny little computers called Raspberry Pis that they put them in, and the adorably sized boxes that they fit in. So they're easy to deploy kind of in that sense. In 2017, Jefferson radiologists, Dr. Bhaskaran Sundaram and Dr. Praslakani, who was the technical advisor for CXR-AI, researched the efficacy of deep learning neural networks in detecting lung changes present in patients with early TB. And I know one of the presenters mentioned this earlier, artificial versus augmented intelligence, and really the fact that we're training deep neural networks to learn. And so what they did was they took 1,007 scans, 68% of them went towards training two networks, AlexNet and GoogleNet, to differentiate between TB positive and TB negative scans. So this is like, for me, med school. Then the other 17% they used to validate the training to ensure accuracy of the materials learned. Those are like the question banks that I dip into whenever I prepare for an exam. And then the 15% of the scans they had left tested the network's capability on the images, on images they hadn't seen before. So those are like, the step one, everything that med students dread at this point in time. And what they found was incredible, right? They found AlexNet and GoogleNet combined had a 96% accuracy in detecting early tuberculosis on chest x-ray after they were trained, which is incredible. And they're clapping for that too, which is fantastic. In Southeast Asia, CXR-AI was used in routine tuberculosis screenings that otherwise screened more sparingly with more expensive technologies like molecular screenings or molecular testing. They partnered with private sector organizations in resource-poor areas to integrate CXR-AI into their routine TB screenings that were kind of already existing. And that was smart because partnering with health screening programs that are already existing takes advantage of the physical footprint that they've already established in resource-limited settings. So you're not kind of starting from scratch. You're working with people that already have community health workers and a network out there, which is very key in if you're looking for sustainable development or sustainable deployment of these sorts of technologies. So they basically deployed the boxes to resource-poor regions by partnering with these organizations. And what they found was that preliminary radiology reports were generated more quickly and cost-effectively with the implementation of CXR-AI relative to what they were using before, which was the molecular screening. So this example can be extended out to remote areas to improve access to appropriate TB care for patients like our 53-year-old woman that we started this case with. The CXR-AI boxes deployed can be placed at remote sites with X-ray machines and automatically run the algorithm on all chest X-rays. They can go ahead and back up the reads from those algorithms as well as the images themselves to kind of a patient report or electronic system or database. They can then, with an integration with something called CXR-AI Connect, send community health workers a mobile alert if something abnormal shows up. Those community health workers now have the option to go ahead and route those images and the read to radiologists for confirmation of diagnosis. And Semantic MD has a whole kind of network of radiologists that they can reach out to so that they kind of facilitate this for individuals. They can also share radiologist reads, the images themselves, as well as CXR AI's read with more experienced colleagues for recommendations, therapeutic recommendations. If you know, somebody isn't as interested or trained in this space, it's a great way to learn, and it's a great way to help patients that don't have access to highly skilled providers. And if they have telehealth or telemedicine or video conferencing technology, they can connect with an expert for further care. And this is harder, but if the patients also have some sort of mobile technology, some sort of smartphone or smart device, they can share the report or the image with patients directly. And it's not unfeasible for this to work. Just as a kind of side note, according to Pew Research in 2017, technology is thriving in emerging economies, right? In emerging economies, 64% of individuals are internet users. Smartphone penetration is at 42%. Both of these numbers are around 10% up from what they were in 2015. So not only do we see here that there is technological penetration in emerging economies, but we see that it's increasing, and it's increasing pretty quickly. And so, you know, as we start to think about the technologies of the future and how we can use them to improve access and quality of care, we can rest easy that these technologies can get out to the people that we want them to get out to. So let's talk about a case where we take this technology, CXR AI, we use it in a place with maybe more technology available, more infrastructure available. So here in the US, maybe in a larger city, let's talk about how we can use it in radiology triage. CXR AI can be integrated with a health system's PACS. It can automatically wet read every scan that the imaging technology that the X-ray machine does, and it can update the EHR with its own preliminary reading. That reading can then be used to prioritize abnormal chest X-rays and radiologist's PACS list. So one of the biggest complaints I heard from the radiologists I work with is, oh my God, we have so many scans, especially chest X-rays. We have to go through every single one, and most of them are normal. Seriously, emergency room, stop ordering chest X-rays, which I'm going in emergency medicine, so I found that quite entertaining. But you know, that was the feedback that I kind of repeatedly got. And when I was looking at this case, something that occurred to me was that technology like this could make it a little bit easier for radiologists, right? They could look at the more kind of emergent scans earlier, because those scans have something, you know, abnormal on them that an AI algorithm has already picked up on. And then they can get to the ones that seem more normal a little bit later on their list. We can now share these reports and the images through phone instead of CDs, which patients, you know, oftentimes forget to take with them to another provider. Or if you're like me and you have a Mac, you don't have a CD side port, a MacBook Air. And this is all really especially useful in emergency care, because standalone or hospital-affiliated EDs or urgent care centers can really benefit from quick access to radiologist expertise, and preliminary results from an algorithm like this could really help guide point-of-care reads and immediate care recommendations. So with that, let's discuss a few key takeaways. This is kind of from the beginning of the presentation, from like the theoretical side of things, and I'd love for you guys to kind of engage at this point. Virtual health solutions, what are they built from? These are like the three big categories that I mentioned.
Digital something.
Digital infrastructure, I'll give that to you.
Health technologies.
Health technologies. And that.
Mobile devices.
Yep, mobile devices. Perfect. To improve healthcare quality and access, solutions often aim to, this is that triple E that I mentioned earlier.
Enhance connectivity.
Correct.
I'm looking at cheat. Empower.
Yep, empower patients.
And elevate medical training.
Yes, perfect. And some key stakeholders to consider when designing virtual health solutions. Who are there? Who are they? Who should we care about? I'll give you a hint. We're all sitting here in the room. That's one of us.
Patients.
Yes. Yes, both of us. Great. There are 2 more.
Payers.
Sorry?
Payers.
Well, all of these, okay, yes, payers. That is true. Patients, yes, yeah, payers. You're correct.
The IT team.
Yep, system administrators, leadership, kind of all of that group of individuals. And there's one more. So the last one is tough and we always forget it. Patients' families. Because these are the people that patients go back to after they leave their clinical encounters. These are the people that take care of them every day. They're oftentimes caregivers, especially for the elderly. They're the people that come sleep in the hospital with their patients, with their loved ones, our patients. Because, you know, that's just how much they care. They're oftentimes more expert at, you know, their loved one's care than the person who just came on to the service and is taking care of them. Especially in peds, you know, the rule of thumb is the patient's parents are always involved in every conversation because those family connections are very important. And it's important that we consider them when we think about what sorts of technologies we make that impact patients and that impact clinical ecosystems and environments where patients are cared for. So with that, I would like to thank everyone for taking the time to participate and be a part of this conversation and this discussion. You can feel free to connect with me on Twitter, LinkedIn, or check my website out. And I'd love to open up the floor to questions or any further discussion. Yes?
So it's 96% accurate as a radiologist report. Why have radiologists? I mean, really, honestly, there is a potential for an AI to be more accurate than what our eyes are going to look at, right?
Yes, but that's why I think that AI is going to be important in guiding decisions that radiologists make, guiding those reads. And they use it already now when it comes to mammography, where you have the device saying, hey, look at this read and there may be something going on here. The radiologist will look and there may be nothing going on there, but they get to make that call because they've seen and they've learned about kind of what is concerning and what isn't concerning. And yes, AI programs look at a lot more images.
I would like to see Watson against 20 experienced radiologists, and I'd like to see the combination.
They have done that for certain diseases.
Yes.
The problem is right now, what the neural networks are trained on is what we as human beings have collectively known, which means the AI networks, as of this time, and I'm not saying this may not change in the future, I'm just saying as of this time are operating off of current knowledge. They're not operating off of being able to
The big thing is they both fail, but in different failure points.
Exactly.
That's the huge benefit of it, is that so you decrease the negative predictive value by not being the same thing. You can do it with 2 radiologists too, sure. That's a lot more expensive.
Yeah, exactly.
That could be true in any specialty. When multiple thoughts, multiple ideas, and multiple knowledge bases put into mechanical learning, that could give a better result than the average. But then the human body is subject to so much variation, can change. There is a human element cannot be replaced ever.
Right. And I think it's really important that we remember that in patient-facing roles, like, you can't ever take off the art of medicine. I'm a big believer in the fact that, you know, the patient-provider relationship is real, and that rapport and that engagement is important. And it's one of the reasons why I fell in love with medicine and I decided to pursue this path to begin with, is that. And I don't think that we should use technology to take that away from medicine, because we're losing a lot
That's
in that
the
sort of
argument
situation.
that we need to be selecting medical school students in different ways. That we're still selecting them so they can memorize everything and they're scientific like, and we're not selecting them to be humanists.
Right.
And we talk about it in our school, all schools say the same thing, and we do the same damn thing. We don't change anything.
Humans are creatures of habit. I think it'll take time, but I think that's the direction people are heading. Yes.
I think the other way to say that is, you know, what do you mean by the art of medicine? Is it the art of being a good listener and communicator, or is it the art of gathering all that information and coming up with a differential diagnosis and a treatment plan? I think technologies can't replace the art of listening and communicating. Therefore, maybe picking the right folks to go to medical school and be a physician. But technology will help actually in the interpretation of images, etc. You can even say that surgery may someday be more standardized because, you just map out the anatomy. You want to do a gallbladder surgery, it's like the machine will tell you cut here. You'll know all of the variances of the, of the anatomy.
You could use
So
augmented
really, the art of
reality.
medicine, you hear people say, well, can't replace me, it's still an art, and I think the art thing is overused.
But a surgeon is an operating physician.
What's that?
A surgeon is an operating physician.
It's a procedure.
Right.
So he has to exercise his discretion.
No, my point is that you can utilize technology in the future to say that a straightforward AbbVie is the same, most of the time, and so the machine, the information, the imaging can actually help plan out the surgery so that you have less variance.
I think a lot of this communication, that art of medicine piece, I think it's a matter of understanding what the differential is and knowing how to convey that in an honest, but not freaking out sort of way to the patient if it's bad, and also being able to communicate what the next steps are and being there with the patient so the patient knows that you're with them through those next steps. Nobody wants to feel alone when they're in their scariest moment, and nobody should have to. And a big part of our jobs as providers is to make sure that we don't let anybody feel that way when they're in our office and when they're visiting us. I won't have an office, but when they're in my emergency room in the future. Well, thank you all for listening. I'm always happy to continue the discussion, continue the conversation, and answer any other questions outside. I love these sorts of conversations and discussions.